Thank you for giving us the time and joining us for a briefing today on children's hospitals in California and our major ongoing issues. Today, we're going to cover a couple of topics. I'm just going to go over the agenda here. My name is Ann Coons, and I'm the president and CEO of the California Children's Hospital Association. We're here today to kind of give you a little update briefing on children's hospitals in general, a little bit about us and our association. And then we wanted to update you on the status of the pediatric surge, which we had a briefing about 6 weeks ago and talked a little bit about the situation that we were in, and we wanted to give you an update on kind of where that stands. And then the next thing we wanted to do was talk about our priorities going forward in 2023 and some of the things that we're going to be talking to you and members of the legislature and other state policymakers about this year. And there are 3 of them, and we'll go over them in more detail as this conversation goes on. And then we'll leave time at the end for questions and answers, and then we'll give you a little update on our upcoming events. So that's our agenda for today. And our speakers are going to be me. I just introduced myself. Jenna Jensen, who's the Vice President and Chief Advocacy and Public Affairs Officer at CHOC. Luis Ayala, who's the Vice President, Government Relations and External Affairs at CHLA, Children's Hospital Los Angeles. Lori Soman, who is the Director of CHRIS, which Lori, it's the Children's Regional Integrated Services System, and which focuses a lot on the CCS program, and is a senior policy analyst at the Lucile Packard Children's Hospital at Stanford. And then Dr. Jolie Limon, who's the Vice President of Academic Affairs and the Designated Institutional Officer and Chief of Pediatrics at Valley Children's Hospital. So those are today's speakers. And before we kick it off, I wanted to give you a little briefing on CCHA and just a backgrounder on children's hospitals real quickly. So CCHA has been in existence for 30 years, and we advocate on behalf of the state's 8 private freestanding children's hospitals and all of the patients and the families that they serve. Our hospitals provide predominantly care to the state's most medically vulnerable and complex children. And we also serve as major training institutions for the physicians of tomorrow, pediatricians, and also, as you'll hear later, other types of primary care providers who need training in pediatrics. Our mission is to advance the well-being of children, promote access to high-quality pediatric healthcare, and ensure the long-term viability of children's hospitals. So some just fast facts about our hospitals. We're 8 private nonprofits. Our 8 hospitals make up 42% of all of the licensed pediatric beds in the state of California. And in terms of the highest acuity beds, PICU beds, we're 62% of all of the beds in California for those sickest children. We see about 107,000 inpatient visits a year, 62% of which are on average Medi-Cal. That makes up about 623,000, over 623,000 inpatient days. We serve almost 2 million visits. We see about 2 million visits on an outpatient basis. Again, about 2/3 of those are Medi-Cal, almost 500,000 emergency visits, and over 1 million clinic visits. As I mentioned earlier, we treat some of the most complex conditions that you will see in pediatrics. We do 73% of the pediatric transplants in the state, 75% of the pediatric heart surgeries, and 64% of all the pediatric cancer patients in California. You may think, well, my hospital, my district or my member's district is not doesn't have a children's hospital in it. However, as you'll hear a little bit more later on, our hospitals really provide regionalized care, and we see patients from all over the state. On the data that I presented earlier, about the patients, we serve some of the sickest patients in the state, the most medically complex children in the state. And so we're seeing patients from all over. And this map on the right-hand side of this slide shows just for the inpatient admissions that we see, and it's kind of gradiated, even in the most rural areas of the state, we're seeing patients at our hospital. So the map kind of shows you geographically where we're located and gives you a sense of where the bulk of pediatric patients are coming from. But I just wanted to, for you to see who our 8 member hospitals are. And while we're on the topic of our 8 hospitals, I want to take a moment and introduce for you the government relations professionals who work at our hospitals and who are available and will be coming to talk to you more this year about our issues. And so if you're, I'm going to do this because we're doing this as a meeting and not a webinar. So, we've got everybody can be on camera. So I'm going to go around and just identify some of our government relations professionals. And if those people would just use the raised hand function so everybody can kind of see who you are. Starting with Rady Children's Hospital, we have Clara Evans and Stephanie Joya Beckman. At Valley Children's Hospital, we have Tim Curley. At Lucille Packard Children's Hospital, we have Sherry Sager and Lori Soman, who's also going to be a speaker a little bit later. Chalk Children's in Orange County, we have Jenna Jensen and Rachel Rolnicki. CHLA, Luis Ayala, who will be speaking a little bit later. Loma Linda University Children's Hospital, we have Chandra Secor. And at UCSF Benioff Children's Hospital, Oakland, we have Jessica Arlene. So thank you all for joining us. I just wanted to give a shout out to those folks. Also want to introduce Amy Blumberg. For those of you who don't know, she's the Director of Government Relations for CCHA and the organizer of this event today. So thanks to Amy for that. And of course, we'll be talking to you throughout the year about our priorities. And just and so this is kind of an introduction, and we hope to have an ongoing conversation with you about our issues. So with that, I want to start by handing over the microphone, the virtual microphone, to Jenna Jensen, who's the Vice President and Chief Advocacy and Public Affairs Officer at the Children's Hospital of Orange County, to talk a little bit about the status of the pediatric surge that you may have been hearing about and kind of what's going on right now. You're on mute, Jenna.
Yeah, for the first thing I'm going to do, I'm going to demonstrate that I still haven't learned how to use Zoom. But first of all, thank you for everybody being on the call today and taking the time to learn more about children's hospitals. We really, really appreciate your interest and your support. So just thank you. I'm not telling you anything that you don't already know about the surge that we experienced. You know this because you read about this in the news. And so these graphs are really a way to illustrate this. Now that we're sort of getting this a little more in our rear view mirror, we can look at the data and say, yeah, that was really rough. So you can look at these numbers in the fall that they started to climb up in late October, early October, and then they really peaked in November. And this was not only RSV, but also COVID and flu at the same time. These graphs are adult numbers. They're not strictly pediatric numbers. But important to note that both with flu and RSV, we tend to see the heaviest impacts on the far ends of the age spectrum. So the pediatric population and the elderly population get hit hard by flu. Flu is particularly dangerous for children. And also, of course, RSV in children who are born prematurely specifically, but we saw kids of all ages getting hit hard by RSV this year. And we had all three of these things come together in a perfect storm that was just so hard for us to navigate at children's hospitals, because it was really, we had talked about the fact that this might happen, but then when it did happen, it happened earlier. And I think it was more dramatic than we even had anticipated. So this is what we saw. This is what the numbers show us. So we can go to the next slide and talk a little bit about where we are now. I know at our hospital, and I know from colleagues that I've spoken to, RSV and flu have definitely started to taper off. They're not gone, but it's really declined over the past few weeks. We're still quite full. We're busy at CHOC. I know others are busy too, but it's more like the typical winter busyness that we would see. So the peak surge is really behind us, but we're still quite busy. I looked yesterday, we had more than 300 patients in our emergency department a couple of times this last week. Those are busy days for us, but it's not like our peak of having, almost 400 patients in the emergency department at one time. Staffing shortages have eased a little bit, although we're still experiencing staffing challenges at CHOC. We're using travelers quite a bit, and we expect that could continue through April to continue using travelers. Supply chain issues are still not resolved. It's taking us longer to get everything. So it's important to note we're still experiencing continued supply chain issues. They're easing a little bit, but they're not over. Our ICU is full right now at CHOC. We're still using our overflow PICU, so very busy, but not like it was. So, and we're still seeing some shortages on some medications and medical supplies. So that's kind of where we are in a nutshell, a little bit more like our typical busy season, but still with supply chain issues, worse staffing problems than we've seen. Not as bad as we had during the peak of the surge, but continued deep concerns about staffing. So I hope that's helpful. And as Anne said, any of you that want to reach out to those of us that raised our hands a couple of minutes ago to find out what's going on in our hospitals, we are always happy to hear from you. So reach out and we can give you the lay of the land as of today. So thanks, Anne. I'll just hand it back over to you.
Great. Thank you, Jenna. And I do want to quickly mention that we have been having ongoing conversations with the California Department of Public Health about kind of what we've learned from this surge and how we might work with the state to kind of prepare for the next pediatric surge, or, the next pandemic, because we know that one may be coming. So that's an ongoing conversation that we will have. Next, I'm going to talk about our priorities for 2023. Before I do, I know we've been joined by a couple other government relations folks from our hospitals. I want to call out, if you could use the raised hand function, Diana Bautista from Packard Children's Hospital, I think is on the line here. If you want, thank you, Diana. And Kristen Pugh from Miller Children's and Women's Hospital in Long Beach has also joined us. So if you want to use the raised hand function, Kristen, and say hi. Yeah, there you are. Thanks. So quickly, I want to just sort of give you an overview of our 3 priorities, and then we'll have our guest speakers kind of go into a little bit more detail. So our 3 priorities for the coming year are going to be: 1, addressing the chronic underfunding in Medi-Cal and the sort of current economic crisis that is occurring for many hospitals across the state, including our members. The second is that we are sponsoring legislation along with the Children's Specialty Care Coalition to modernize the California Children's Services Program, which provides care to some of the most medically fragile children in the state. And the third priority is really more of a regulatory administrative priority that we're not going to be coming to the legislature with, but one that we want to make you aware of, related to trying to really help support the pediatric workforce in California. So those are our 3 priorities. And to kick it off, to go over each one, I'm going to start with Luis Ayala, the Vice President, Government Relations and External Affairs for Children's Hospital Los Angeles, to talk about our budget priority. Luis?
Thanks, Anne, and thanks everybody for joining today. I wanted to just start off by mentioning that children's hospitals are disproportionately dependent on Medi-Cal funding. It's essential to the funding for children's hospitals as their providers. And approximately 2/3 of our children's hospitals patients are on Medi-Cal. For some, such as CHLA, as much as 70 to 75%. In our case, we're at about 74% Medi-Cal. And it doesn't cover cost and rates, and rates have actually not increased for hospitals in over 10 years. In fact, we did a little bit of analysis, and internally over the last 6 years, personnel costs have actually gone up by 34%. Drug costs have gone up by about 57%, yet the Medi-Cal reimbursement rates have declined by about 25%. So if you just do some quick math in your head there, it gives you a little bit of perspective of some of the finances that we've had to wrestle with when it comes to Medi-Cal reimbursement in the state. And so these rates are unsustainable to pay for patient care. And so if we go to the next slide, you can see that children's hospitals see almost twice as many Medi-Cal patients as a typical non-children's hospital. So you see there 64% versus 37%. So the more we continue relying on Medi-Cal as children's hospitals and attending and being the safety nets of our communities, the more we, unfortunately get dinged, and the more that we have to wrestle with our finances internally. And so, as you've seen, I think there was a closure of a hospital in Madera recently. And so some hospitals are having to make decisions such as that, which is an extreme case, but it's a reality. And it seems like, it's great that the state is increasing coverage of our underrepresented populations, our Medi-Cal recipients, but the provider rates, as was mentioned have been frozen when it comes to Medi-Cal for the last 10 years. If you go to the next slide. So we've got a budget priority to address the chronic medical underfunding. I think everybody's aware now that based on the governor's recent budget release, there's a projected substantial deficit. And so, but at the same time, children's hospitals have been devastated by the finances of not just the pandemic, but again, the accumulation of declining reimbursement rates over the years. And so we are making a request for $1.5 billion. It's a one-time general fund grant that would be distributed to hospitals based on their Medi-Cal share. I know a lot of the details have not yet been released or developed, so we're in the process of that. So we wanted to bring that to your attention, and we hope that over the next couple months, we can continue having that conversation with each of your offices to see how we might be able to make this happen. I won't go through the rest of it because I think it's repetitive, but I'll leave it there. And Anne, you're back on.
Thank you, Luis. So you'll be hearing a lot more about this, not just from us, but also from the California Hospital Association and the other constituency hospital groups. It is the #1 priority of the overall hospital community because, as Luis mentioned, it is a real economic crisis for our members. The second priority that we want to talk to you about is our legislative proposal this year. We are seeking legislation to modernize the CCS program. And here to talk a little bit and give you a little background about the CCS program is Lori Soman, who I introduced earlier. And Lori, I'm going to turn it over to you.
Thank you, Anne. Happy to be here. So CCS is the oldest public health program in the state. It was established in 1927. It was designed specifically for children with special health care needs. It's not an insurance plan. It's a medical case management and a pediatric quality assurance program. It provides diagnosis, treatment, and medical case management to about 200,000 kids up to age 21 who have complex health conditions and who are low income. So as you can see there, about 90% of the kids in CCS are in Medi-Cal. The rest have family incomes below $40,000 a year, or they have catastrophic out-of-pocket costs for the CCS condition. CCS serves the state's most medically fragile pediatric population: kids with cancer, sickle cell, cystic fibrosis, severe burns, congenital heart disease, kids who need organ transplant. And the CCS program sets the treatment standards for pediatric specialty care in California as a whole. And these standards serve to benefit all children in the state. And finally, the program has historically been carved out of Medi-Cal managed care. Next slide, Anne. So there's a close working relationship between CCS and the children's hospitals to serve these kids and their families. So as you can see, we offer a broad array of CCS-approved inpatient and outpatient special care centers for kids with complex medical conditions. And the majority of CCS claims for both inpatient care and medically complex care are for services that are provided at children's hospitals. Next slide, please. CCS program is one with a history of working well for kids. The infrastructure supports the very specific needs of kids with medical complexity. So the statewide pediatric quality standards, the regionalized system of providers, they drive the pediatric system of care for all kids in our state. The CCS provider network is statewide and it's beyond. So if a child needs access to an out-of-state provider for their specific condition, they can get it. So just to note, this is unusual. Highly specialized pediatric providers like that are not typically in managed care networks. And then the other component of the infrastructure is this individualized intensive case management by CCS program staff that ensures that these kids get the right care at the right place at the right time. And then finally, this classic CCS model has excellent outcomes and high family and provider satisfaction. So let's go on to the next slide. What is this classic CCS model of care? Well, as we said, the CCS services are carved out of Medi-Cal managed care. So the responsibility for medical care for these children is actually split. Care that's not related to the CCS condition, so that's going to be typically primary care and related things. That's the responsibility of the managed care plan and its provider network. But the management of care related to that complex CCS condition, including intensive medical case management, that's the responsibility of the CCS program. And this intensive medical case management is typically provided by county CCS staff, nurse case managers working with physicians and other staff as needed to authorize children's access to the providers that are appropriate for their specific conditions and to ensure that families get to that care. And that's that green circle up on the right. That's the piece that reflects the role of the county CCS program. Next slide, please. So our State Department of Healthcare Services has actually launched a new model for CCS called the Whole Child Model. This is currently in 21 counties only. They're all what are called county organized health system counties. A single plan operates in that county. And there are about 30,000 kids enrolled in Whole Child Model among all these 21 counties. So how does this model differ from Classic? First, CCS is carved into Medi-Cal managed care. So now the Medi-Cal managed care plan in those counties is responsible for all care for children, including medical case management and authorizations for complex conditions. And those CCS program staff that I talked about, nurse case managers, et cetera, they are no longer involved in these counties in authorizing care appropriate to the conditions. That is now the plan's responsibility. And that's why you've got that giant red X in that circle in the upper right. Let's go to the next slide. This leads us to two major concerns about the Whole Child Model that we want to put on the table for you.
Same slide.
Oh, sorry.
Yeah.
You stay on the same slide. Yeah. Sorry about that. So there are two major concerns that we've identified about the Whole Child Model we want to put on the table. And the first concern is the 30,000 kids who are now currently enrolled in that model in the 21 counties. We have seen data that suggests that they are actually receiving a lesser level of care when compared to the care received by children in classic CCS counties. So this becomes an equity issue. And then the second concern involves the potential impact on the pediatric system of care itself. So delegating responsibility for CCS to insurance plans, which is the Whole Child Model, could have unintended but still serious negative impact on the CCS program's critical role in setting and enforcing those pediatric quality standards. And as we said, those standards are critical to the system of care for all kids in California. So I'll close there, turn it back to Anne. Thank you.
Thanks, Lori. Before moving on to our proposal, which is on the next slide, which you briefly saw as I advance the slides, I just want to highlight something and make something really clear. We don't have, we work really closely with managed care plans, and we have good relationships with them, and we don't want to imply that managed care plans don't do a good job generally. I think our kind of concern about Whole Child Model is that it really does potentially impact the regionalized system of care that crosses county boundaries and that has supported, is sort of the backbone of the entire program. So it's really that concern, and our thinking about this is that it's not necessary for something to be carved into managed care in order for it to work well with managed care. And the department itself has taken, the Department of Healthcare Services has taken that approach. They've carved drugs out of the entire Medi-Cal managed care program and have a separate program for Medi-Cal RX. So Medi-Cal managed care plans coordinate with a lot of services, and they've historically always coordinated with the CCS program. And we think that's a model that we would like to see continue. And so we want to work with the current Whole Child Model counties. They do, we have good working relationships with those plans, but the issue is that we don't really want to see an expansion of the Whole Child Model at this point. So as Lori mentioned, we do have a bill, and I want to take this opportunity to call out Erin Kelly. I don't know, Erin, if you're on, if you could use the raised hand function to say hello to the group. We are co-sponsoring legislation with the Children's Specialty Care Coalition, and Erin Kelly is the executive director of the Children's Specialty Care Coalition. And the Children's Specialty Care Coalition is the organization representing the pediatric specialty physicians, many of whom work in our hospitals. So this is thanks, Erin. This is a collaborative effort with the Children's Specialty Care Coalition to sponsor this legislation. And this legislation does a couple of things. And our overarching reason for wanting to pursue legislation in this area is really to preserve the program. We're really interested in modernizing the program to meet sort of the changing dynamics that are going on in the last 20 years. And also to preserve it, because we think it's a really important piece of access for these most medically complex children. So what does our proposed legislation do? There's sort of six major components. One is that we want to place in statute the medical conditions, the conditions that make a child eligible for CCS, because right now they're in regulation and could be subject to change without legislative oversight. So we wanted to put those conditions in legislation and also require the department to periodically review with a panel of experts if there should be any new conditions added to the CCS program, if other children would benefit from that intensive case management that the program provides. Secondly, we want to modernize the financial eligibility portion of the program. A lot has happened since the statute was first created for CCS. You probably, when Lori was going over those eligibility criteria, there's this $40,000 number that's in statute that's clearly outdated because it was before the Affordable Care Act, before CHIP. So really what we're looking at is trying to modernize and sort of seek harmony with the Affordable Care Act for children who may not be eligible for Medi-Cal, but we don't want a family, they may have skinny insurance, for example. They might have an association health plan or something that doesn't provide full benefits, and we would never want to have a family of a child with a CCS condition risk losing their home because they don't have adequate coverage. So we're trying to address that problem. The third thing is we want to address the sustainability of reimbursement for CCS services. Physicians haven't had a rate increase for CCS services since 2001. And I think as Luis was mentioning earlier, for CCS, for hospitals, for CCS services, our hospitals haven't received a rate increase since 2012. So we've experienced this intense inflation, and we can't, it's not sustainable. We can't sustain the program if we don't make those investments. The fourth thing is really addressing the really unsustainable cost of high cost breakthrough drugs. These drugs are great. They're life-changing for children, but the way the Department of Healthcare Services reimburses them is very inequitable relative to whether they're provided in a hospital or an outpatient setting. And some of these drugs need to be provided in an inpatient setting. So we're requesting, we're proposing site neutral payment. So it should be the same whether it's inpatient or outpatient. The fifth thing we're looking at is really maintaining the status quo with respect to whole child model. So not expanding the whole child model any further than it already exists. And then finally, we want to be respectful about the fact that the environment, the fiscal environment where we are currently finding ourselves in, and we feel like we need to respect the fact that there may be some times when the state's in a deficit and some of these provisions would be costly for the state and maybe not viable in a deficit situation. So we've added a trigger to the proposed legislation. So we will be talking to all of you more about this in the coming months. This is a big priority for us. So you'll hear more about it, but we wanted to use this opportunity to introduce the concept with you. So that was our second priority. And now for our third priority, I want to introduce Dr. Jolie Limon, who I'm not sure I did introduce you earlier, Dr. Limon. She is the Vice President of Academic Affairs and the designated institutional official, which is the person who's responsible for the medical education and workforce training at Valley Children's Hospital. And she's also the Chief of Pediatrics. So welcome, Dr. Limon.
Thank you. Thanks, Anne. Good afternoon, everybody. And thanks for the opportunity to tell you a little bit about workforce and pediatric training programs. Before I get started, as you mentioned, I'm coming from Valley Children's Healthcare, which if you're not familiar, we're a freestanding children's hospital in the heart of Central California. And we serve about 12 of the counties in the state. And behind me, and a lot of people comment about this guy, so I thought I'd just tell you who he is. He's our mascot. His name's George. And we chose the giraffe as our mascot because the giraffe has the largest heart of any land mammal. So little trivia there for you. So just a little also about myself. I'm still a practicing pediatrician and actually taking care of patients this week. So I can attest to you that children's hospitals are incredibly important for taking care of our most fragile and complex kids. I took care of a kid with a metabolic disorder this week where there are only 44 cases reported in the world ever. And so, you know, we really need our children's hospitals to be able to take care of those kiddos and really to also train our pediatricians for future generations. So as we talk about workforce, our pediatric residency program here has been up since 2017. We have graduated a total of 38 residents with a retention rate of 50%. And that's so important for our population and for our state. As Anne mentioned, there are 8 freestanding children's hospitals in the state of California. And as children's hospitals, we're responsible for training over half of the pediatric residents, as well as 10% of fellows. And fellows are just those doctors that go on for further training. So your pediatric cardiologists, your pediatric gastroenterologists, etc. But we don't only train pediatricians, which I think is a critical piece that sometimes isn't understood. We train hundreds, and we literally, I'll show you a little bit in a moment, we train hundreds of other residents that then take care of our state. So family medicine, emergency medicine, surgery, OB-GYN. And when you look at the number of training programs in the state that are dedicated to family medicine or internal medicine, they far exceed what is out there for peds. So there are only 17 pediatric residency programs in the state of California when 25% of the population of the state are kids. So just really critical. And then there are some numbers over there you can look at. We'll go on to the next slide. So I think this slide speaks, you know, pictures worth 1,000 words. And what this slide shows is all the children's hospitals in California. These are not, some of these are not freestanding. Some of these are children's hospitals within adult systems. But I did want to show you kind of where the under-accessed areas are. And if you look at the numbers, so the white areas show that for every subspecialist, ped subspecialist, they take care of about 3,000 to 4,000 kids. So then if you look at the Central Valley specifically, which is one of the most impoverished areas of the state, we take care of 1.3 million kids. Our access is, you know, we only have one pediatric subspecialist per 10,000 to 18,000 kids. And so this was really one of the main reasons we as an organization started a training program and are really committed to keeping our grads in the Valley and accessing some of our poorest kids of the state. On the next slide, I just wanted to give you a snippet of who we train, because I think this is not unique to us as a children's hospital, but it's surprising to most. So we actually train more family medicine doctors than we even train pediatricians. And we train 2 pediatric residency programs, our own, and then one at UCSF Fresno. But you can see we also train surgeons and orthopedic doctors, anesthesiologists, etc. So it isn't just about being there to train our pediatricians of the future. It's really all providers of the future. Next slide. The next slide just shows the discrepancy between CMS funding for adult facilities and adult GME versus CHGME, which is the carve out that goes to children's hospitals to help fund our trainees. And you can see that our CHGME funding is roughly half of what other residency programs get. And I can tell you personally, we train with all those other physicians I showed you about a total of 55 FTEs a year. We receive enough funding to cover 10 of them. And so that means the rest of the funding is coming from other grant monies or our own operational budget. So, you know, it only covers about 13% of what it costs to train all the doctors that we are giving pediatric education to. Next slide, please. So at the state level, we'll be working to seek modifications in the HCI training program application. So this is Song Brown. Right now, the application for pediatrics seeks we have to have 8 hours of primary care or clinic work, and that does not align with what is required from our accrediting body. So it really doesn't match up. In addition, many programs are receiving this funding at a much higher rate, and we are training those residents and not receiving that funding. So I think there's some opportunity in looking at how these programs are set up, how their scoring systems are determined in the future. And then lastly, at a federal level, we'll be seeking additional CHGME monies, more commensurate with the adult program funding, and hope to balance that out a bit. And that's what I have. Thank you.
Thank you, Dr. Limon. So now we'd like to open it up for questions for any of the issues that we've raised or any other questions that you might have about children's hospitals or pediatric workforce issues or pediatric issues, healthcare issues in general. All of us here have a lot of years of experience, and we'd be happy to answer any questions that you might have. So you can either type them in the chat or raise your hand, and I'll let Amy moderate those questions.
So the first item that we had in the chat was from Joe Para with the Senate Republican Caucus related to CCS and whole child model. I think the slides may have answered the question, but Joe, did you want to ask a question?
I agree. The slides answered my question. I was pretty sure I knew the answer. I just wanted to confirm. You never want to assume, but thank you.
Nice to hear your voice, Joe.
Same here, Ann.
All right, and then there was also a question from Don Adler with Senator Quirk-Silva's office, asking about direction for reports for the current CCS model, and then also wondering if there is a bill number or author for the CCS modernization legislation.
I can take answer the second first. I'm not sure I understand the first part of the question, but so our author is Senator Durazo, and we don't have a bill number yet because the bill is not back from council. As far as the report goes, did you mean the evaluation or? I'm not sure if you can come off.
I'm
mute.
sorry. Hi, Anna Louise. What I was looking for is, since you are doing this bill on modernization, is there any reports or studies that you've done that compares the old model, which has been done for decades and was doing fine, to what unfortunately is being done now? Now that you're moving on to try to fix whatever. Is there anything that you could send me that I could read that compares and how the current model is doing?
Yeah, so a couple things about that. That's a great question. There has been some data, and I think Laurie was referring to some information that Chris, that she works with, has been collecting. The department is actually required under the law to provide an evaluation to the legislature. It was actually due in December. They haven't provided it yet, and we need to see kind of what their study results indicate. I would say that, in general, like I said before, we have a good working relationship with those whole child model plans. So I don't want to leave you with the impression that, like it's a complicated picture, I guess is what I would say. But we definitely have concerns about how the potential for it to be very destructive to the overall statewide network. And we can share with you some of the more detailed information that we've developed. We've actually put together an FAQ document that we'd be happy to send out after this. We're going to send out the slides after this presentation, and we'd be happy to send that to you also. And then we're waiting for the department's evaluation to come out. And when that does, we'll take a look at it and see what that says too.
Thank you. Yeah, I was frustrated. I thought it was supposed to come out already. So thank you for clarifying it.
Yeah. You're not alone. We're all wondering where that is. Yeah. So, other questions? Anything else, Amy, in the chat or?
No, people that are happy to get the slides.
Okay. Before I give the slides, I want to do a save the date and let people know about some upcoming events. So we're going to be doing our Resident Advocacy Day on March 22nd. So we'll be looking to meet with you and your member on that day. The other thing is we are going to be hosting a legislative reception from 5 to 7 p.m. at MyOL, and we hope you'll be able to join us. And we'll be sending out some invitations for that event coming up. And finally, to end, I just want to say thank you to you for making the time to join us today. I want to say thank you to Amy, who helped to put this all together. We will send out a PDF version of these slides along with some additional information about our proposed legislation. And I just want to say thank you again for making the time. And thank you to our presenters.
And can I just flag really
yeah.
quick? I think Anthony Archie had a question about of the $1.5 billion in potential grants.
Mhm.
The budget request, roughly how much would go to Children's Hospital? And I think the answer is that's still under development, unless you have any other updates.
I don't have any other updates. What I understand is that level of detail is still being worked out. I'm just going to go back to the question slide. And it would be based on your Medi-Cal percentage. So while I don't know exactly how it would lay out for children's hospitals, because we're so high volume Medi-Cal and because we are facing some immediate distress, we would expect to, to get maybe more than an average community hospital on a per patient basis, just because our Medi-Cal percentage is so high.
Thanks for catching that additional question, Luis.
Yeah, thank you.
Thank you, Luis and Louise.
Of course. Thank you again, everyone, for taking the time, and we look forward to working with you in the coming year. Please feel free to reach out to Amy or I or any of the other government relations people on this call if you have any questions.
Thank you.
Thanks, everyone.
Thank you.